Yeah, I'm thankful to Tamil Nadu ISG for the kind invitation. So, in this session, we are going to have two very interesting Indian studies. And the first study will be presented by Dr. Veera. He is a close friend. And Dr. Veera is a senior consultant in the NMC Hospital, Abu Dhabi. Over to Dr. Veera.
Thank you, Dr. Vikas, for giving a kind introduction. I'm going to share my slides, so kindly allow the chairpersons to bear with me 1 minute. So now sharing of the screen has been done. So now I'm going to start the presentation. Yeah. So the study which I done was in 2017. It is to find the efficacy of simethicone and N-acetylcysteine combination pre-medication prior to esophageal gastroduodenoscopy to improve the mucosal visibility. Yeah, prospective double-blinded randomized placebo-controlled trial registered with the CTRI. So my co-authors were also shown here. These are my disclosures that a study drug has been given by the Delvin formulation initially for the free of cost. So this is just a background of my study. There's a patient A profile, and this is patient B profile. Patient A clearly had a lot of mucus and bubbles, and which has been flushed with with the study, and means by flushing it shows lesions here. And also similarly, the patient B we can see as clear ulcer. If it should have been missed if we are not flushing it. So with this background, we done this study, and India there was no such recommendation. Only one study in the abstract form was there at the time in 2017, and overall there was a limited literature. But it was a routine practice in Japan, China, Taiwan, Korea, and now in UK, and which was not there when I started the study in 2017. So the aim of the study is to detect whether the combination of simethicone with N-acetylcysteine improves the mucosal visibility before the upper GI endoscopy if we use. So the outcomes, primary outcome, to find the effectiveness of simethicone with N-acetylcysteine combination for better mucosal visibility using total mucosal visibility score, which I will come across later when I am describing it. Total mucosal visibility score is detected with a calculator from calculating from the esophagus, in the esophagus, upper esophagus and lower esophagus, and also in the fundus, upper corpus, lower corpus, antrum. So in stomach 4 regions, in esophagus 2 regions, and duodenal bulb 1 and duodenum second part of the duodenum as second. So totally 8 regions were evaluated in this total mucosal visibility score. Secondary outcome is to estimate the total duration of the procedure time for each patient in various arms of the study groups, and to estimate the number of lesions detected in each study groups. So the method of study design, it's a prospective randomized placebo-controlled trial in which there were 4 arms. First arm is group A, that is simethicone 150 mg with N-acetylcysteine 600 mg mixed with 75 ml of water. This emulsion is 15 ml, and the rest 75 ml has been mixed with water, and it has been given. That is group 2 is simethicone 150 mg alone, and group 3 is N-acetylcysteine alone, and group 4 is placebo. There is water alone, and it is a 2x2 factorial study design. Study area is the Department of Gastroenterology, Pondicherry Institute of Medical Sciences, India. When I was working in 2017, I was working there. The target population was patients undergoing gastroscopy. The inclusion criteria is all the patients undergoing diagnostic upper GI endoscopy age more than 18 years, and the exclusion criteria is partial or complete gastric outlet obstruction patient has been excluded. Patients who are not fasting less than who are not fasting more than 6 hours were excluded, and others were patient who had a GI bleed, pregnant patients, post gastric surgery undergone patients, and phenylketonuria patients who had a little hypersensitivity to trial drugs. Period of study is September 2017 to March 2018. The sample size was calculated based on the total mucosal visibility score between the groups and the placebo to be at least 2 plus or minus standard deviation 0.5, and the sample size has been estimated to be at least 192 participants, total 768 patients overall, with an alpha error of 5%, beta error of 20%, with a error margin of 0.1 and power of study of 80%. So this is the randomization which has been done. The randomization has been done in 1:1:1:1 ratio by the sealed envelopes. So this is group A, group B, group C, and group D. So group A, all the groups had 192 patients, and they were all blinded. Which trial drug they were getting based on the sealed envelopes. So the study was registered with the clinical trials registry. After 20 minutes of consuming the solution, the EGD was done, and multiple images has been taken in various regions, which I explained before. And after finishing the procedure, the endoscopists were also blinded to the study drug, and two endoscopists were involved, myself and another doctor, Dr. Josh Korean, both were involved in the study. And the blinding has been done by our departmental staff, the endoscopy staff nurse and the technician. So the total mucosal visibility score, the total duration of the procedure, and the total number of lesions detected were all analyzed after the study, after each endoscopy has been done by each of the endoscopists. The statistical analysis has been done by the continuous variables by chi-square test, and the categorical by one-way ANOVA, Tuckey's multiple comparison test, and Pascal Wallis Bonferroni collection analysis. P value less than 0.05 has been considered significant. So coming to the results, so the baseline characteristics were comparable between each groups, and there was no significant difference. And the total mucosal visibility score was clearly low. That is, if there is a lot of mucus or bubbles, it is score has been given as 4, and the less number of mucus or bubbles, the score has been given as 1. The as much as low means. So this is the total mucosal visibility score of Group A, Group B, Group C, and Group D has been shown here. So the difference between them has been clearly significant with a p-value to be less than 0.05 compared to other groups, and also with individual groups. And in this, if you see in the lower purpose, there was not much difference between the simethicone and NSL combination group compared to simethicone alone, as has been documented. But still, in other regions, everywhere it was showing clearly significant. So pairwise comparison analysis by Pascal Wallis Bonferroni correction has also been done, which was also showing clearly in different locations that the mucosal visibility score was better. Overall foam or bubbles obscuring the vision has also been calculated and measured. So this is the Group A arm, in which blue is less than 25% of the mucus obscuring the vision. So you can see that this arm was having a maximum number of patients compared to placebo, where only 65 patients were there. So like that, the total duration of the procedure has also been calculated. So combination arm, that is Group A, simethicone and NSL cysteine, was only 5.27 minutes compared to Group D, 6.97 minutes, with a significant value, p-value. Patients' comfort during the procedure was also better with simethicone compared to placebo, because the total duration of the procedure was also more in placebo compared to combination arm. So probably that could have been a reason. Need for frequent flushing of water was also less in simethicone and NSL combination compared to placebo alone. So this yellow is the no suction or flushing needed, but still few patients needed, but still there was a significant difference. Number of patients detected with lesions were also little more than in Group A compared to Group D. So discussion, as Dr. Around four of the studies has been quoted in this peer review journal, which is under peer review. Among them was one of that was Dr. Pradeep Bhandari's paper in Scandinavian Journal of Gastroenterology, published in 2010, which has been already discussed by him itself. So others were Chang et al., which has been published in Journal of Gastroenterology and Hepatology and World Journal of Gastroenterology, and Ashel et al. All of them compared this total mucosal visibility score as the main parameter, and the total duration of the procedure was also taken into consideration. So in this, it has been shown that combination worked well than either a drink or a spray or used alone or placebo. So the strength and limitation of the study. Strength is it's a large placebo-controlled trial which compared 3 agents together with the placebo. Limitation, still the total mucosal visibility score is a subjective one, and more objective one of detecting neoplasias is needed, which is need to be answered in future trials. Thick bile, food debris, or blood may still obscure the vision. Conclusion: premedication with simethicone and NSL cysteine markedly improved the mucosal visibility, reduced the time duration taken during the procedure, and improved the patient comfort and detects more lesions probably. This low cost and well tolerated intervention may improve the mucosal visibility during the endoscopy. Thank you. Thank you so much.
Thank you, Dr. Bira, for the excellent talk. And the next study will be discussed by Dr. Shrihari Nikhandi. And Dr. Shrihari is a consultant at Sir Gangaram Hospital, New Delhi. Over to Dr. Shri.
Thank you so much, sir. I hope my screen is visible, sir.
Yeah, we can see the slides here.
Yeah. Thank you very much. Thank you, ISG Tamil Nadu chapter and all organizers for giving me this opportunity to present on this elite platform. So I would be presenting my study, which was a study conducted to see the role of a pre-endoscopy drink of simethicone and N-acetylcysteine, whether it improved the visualization during upper GI endoscopy. Dr. Vikas was also a part of this when he was at Gangaram Hospital, and we took most of our inspiration from Professor Vedo when we were at his center. So as we all know that many centers, so this study was basically focused more on how we could use this pre-endoscopic preparation in the Indian context, because already in the West and in the most good centers in the East, they have already been using this since a long time. But in India, this is still not used very frequently. So many endoscopy centers in India have now started recently focusing on advanced endoscopic modalities like NBI, EMR, or ESD. And a good pre-endoscopy preparation is very essential before commencing these procedures so that we can have an unhindered and detailed evaluation of the gastrointestinal mucosa. Now, most of us, when we are doing our conventional endoscopies, especially in India, I think most of the audience here would agree that this is a typical kind of an endoscopic picture that you usually get. A stomach full of bubbles, especially now during the winter seasons. And it becomes really difficult to see for the mucosal characteristics when you have preparation of this kind. So I was to Professor Vedo's center around a year and a half back, and it was there when this entire idea started. So when I was at his center, I found a very unique thing that when the patients entered the endoscopy room, most of them were given a drink to drink. And initially, because we were not aware of this concept, I thought whether is this something kind of a welcome drink that the patients are receiving. But then on discussion, Dr. Vedo said that this was for a purpose. This was for a reason, that it contained a mixture of a proteolytic enzyme and a defoaming agent, which helped improve the visibility. So these were the kind of the endoscopic images which were achieved only because of an excellent pre-endoscopic preparation. And this was how this entire idea started. So for this study, the introduction was that for colonoscopies, a pre-procedural preparation has become a norm, and this is a norm all over the world. However, there is no standardized preparation recommended prior to upper GI endoscopy. In most centers in India and around the world, the only requirement that is used often is fasting, which we ask the patients to fast for around 6 to 8 hours prior to doing an endoscopy. Our study was a retrospective investigator blind study with a case control study design. For the enrollment, we included patients with dyspepsia, GERD, patients with chronic liver disease in whom portal hypertension was to be evaluated, patients with unexplained anemia, unexplained weight loss, those presenting with chronic diarrhea or recurrent vomiting. Patients who had acute or ongoing upper GI bleeds were excluded. So were patients with, who were pregnant or lactating, people with known hypersensitivity to simethicone or NAC, those with esophageal strictures or gastric outlet obstruction or any post-surgical altered anatomy, those with severe cardiorespiratory illness, in people who there was a significant amount of food residue either because of gastroparesis or otherwise, or others with significant esophageal or gastric inflammation because of corrosive intake, viral or fungal etiology, etc. And those who were unwilling for giving a written consent for this study. So what we used for this study was that all patients were administered a pre-endoscopy drink anytime between 10 to 30 minutes prior to undergoing the endoscopic procedure. This drink included 100 ml of water, N-acetylcysteine effervescent tablet, which is commonly available in the market of 600 milligrams, and 1 ml of simethicone, which is equivalent to around 60 milligrams of simethicone. Post giving this drink, endoscopy was done with either the Olympus 180 or 190 series, and all the procedures were done with under sedation with 2 or 3 milligrams of intravenous midazolam. Electronic photographs were captured at 6 predefined locations. This was in the lower esophagus, in the fundus, body, antrum, D1 and D2. And these images were then stored digitally. And later on, they were analyzed by an independent investigator who was not aware of what these patients had received, and he was completely blinded. So this was a third person. Two people performed endoscopies. The investigator who analyzed the images was completely blinded to what was done. So a set of digital images of endoscopy of both the cases and controls were provided to a blinded investigator who was not a part of any of the endoscopic procedures. The investigator was then asked to mark the mucosal visibility on a 3-point scale at the 6 endoscopic sites, which we previously discussed. The 3-point scale which was used was a score of 3 or poor was given if there was a significant amount of bubbles or mucus, which actually obscured the mucosal vision. A score of 2 or suboptimal was given if there was a small amount of bubbles or mucus, which did not completely hamper the mucosal vision. And a score of 1 or excellent was given when there was a clear visibility of mucosa with absolutely no bubbles or mucus. So we started giving preparation for patients from around January 2020, and the cases were included from Jan to March 2020. Around 244 cases were included, and exclusions based on the exclusion criteria were done, and eventually 108 cases were used. For controls, we used those patients in whom endoscopies were done between October and December 2019. And propensity score matching was used because this was a retrospective trial. Based on the exclusions, we matched around 108 patients on both the cases and control side, and eventually 106 controls and 104 cases were used as a part of this study. On matching, patients were matched, both the cases and controls were matched for age, sex, and the indications for procedure. So there was no significant difference in the baseline demographies of these two groups. However, when we saw the effect of preparation of NAC with simethicone, we found that the mucosal visibility score was much lesser or much better in esophagus, in fundus, body, and antrum of the stomach, as well as the duodenal bulb. However, we did not find a significant difference between the visibilities, though visibilities were better, but the difference was insignificant at the second part of duodenum. Also, the number of patients who had excellent preparation, that is, absolutely no mucosal bubbles, were significantly higher in all the regions except an insignificant difference which was seen in the second part of duodenum. An important part to highlight, which was also highlighted by Dr. Bhandari, was there were absolutely no adverse events with this drink. Not a single case of aspiration or hypersensitivity was noted during the in any of these patients in this study. So as a part of discussion, now when we ask the patients to fast, pre-endoscopy fasting, the fasting helps in clearing the food residue from gastroduodenal lumen, that we all know. But what it does not do is that it does not help in the reduction of air bubbles or in the reduction of mucus. So air bubbles, which we see in the stomach, are produced due to trapping of gas in the water molecules present in the GI lumen. And gas in the GI lumen is derived either because we swallow air or during fermentation by the gut microbiome. So around 20 ml of gas is present normally in the gastric lumen. What simethicone does is that it leads to a reduction in the surface tension of these air bubbles. So these air bubbles coils very easily, and they're very, very easy to be dispersed of. So when there is a reduction in the surface tension, they can be dispersed of very easily, and hence we are able to clear out the air bubbles very easily. On the other hand, mucus. So a mucus gel, which is normally overlying on the gastric mucosa, it contains a large amount of water, but what it also contains, a very important component, is around 5% of glycoproteins, which are cross-linked in nature. So it is the glycoprotein component which keeps the mucus in the viscous and the fluidic state. So what happens with fasting, Dr. Vedo had just touched upon it, was that with fasting, the glycoprotein content declines, and this reduces the fluidity of the mucus layer. So hence you encounter a sticky mucus. The more the patient is fasting, you would notice that the mucus becomes stickier and stickier, and it actually is very difficult to flush. What N-acetylcysteine, being a proteolytic agent, it does is that it breaks the disulfide bonds in the glycoproteins, and it destabilizes these extracellular proteins. So it becomes very easy for us to flush the mucus out of the stomach. So in our study, we found that there was a significant improvement in mucosal visibility with NAC plus simethicone, seen in all regions of the, in esophagus, all regions of stomach, and the duodenal bulb. However, in second part of duodenum, the difference was insignificant, probably because we used around 100 ml of water, which might not be sufficient to clear out the distal duodenum. So nowadays, the use of simethicone is also being propagated for colonic preparation. So for that, for either for video capsule endoscopies or for colonoscopies, we might require higher volumes of preparation than the conventional, which we use for the endoscopy. The pre-endoscopy drink was given between 10 to 30 minutes prior to endoscopy. So this conforms to the gastric emptying time for water, which is around 30 minutes. So there is a previous study which quoted that after 30 minutes, there is no significant difference, irrespective of whether you give the drink or not. So this time before 30 minutes is crucial. As I discussed, there was not a single event of aspiration. So that dispels the most commonly held fear, especially among the Indian endoscopists, that there might be a risk of aspiration when you use this drink. Obviously, the study had a few limitations, that it was retrospective in design. However, we took an adequately matched group by using a propensity score matching. So possibly there was good correlation between the two groups. The lesion detection rate was not assessed. This was because there were two different endoscopists with differing experiences. So we could not compare both of them. Endoscopists were not blinded to the preparation which was given, but this is unlikely to affect the study outcome, as the only job of the endoscopist was to take standard images. The investigator, however, who analyzed the images, was blinded. So in conclusion, the pre-endoscopy drink consisting of NAC with simethicone, it significantly improved the mucosal visibility. It was very easy to prepare. It was very cheap, costing us less than $1. There were absolutely no adverse events. And one thing which we have not highlighted in this study, obviously because this was not a part of the trial, was, but based on experience, I can vouch that it actually reduces your procedure time to a significant extent. Because what you don't have to do is keep on flushing water, which usually takes time to clear off all the bubbles, and the bubbles keep coming back, and the mucus is especially difficult to flush. So instead of spending time in flushing water again and again, we could utilize this time in making a good observation of the mucosa and detecting any subtle lesions. So it actually reduces the procedure time and might be very useful in most of our endoscopy centers in India, which are usually overburdened and understaffed. So we are a nation which is obsessed with visibility. There are so many ads which focus on visibility of a person. I'm sure with time, we'll be accepting an improvement in the visibility even for endoscopic procedures. Thank you very much.
Thank you, Dr. Shri, for the wonderful presentation. So I think we can take the few questions here. Regarding the anesthesia during the endoscopy, in your study, you use the midazolam, and that doesn't give the complete sedation. Okay, a patient is still conscious, they have the gag, and some centers are using propofol that achieve a deeper level of sedation. So do you think the preparation should be different for the center which are using the propofol?
Sir, absolutely. I think it all depends on the indication of endoscopy. If you think that the patient is high risk and the intention for doing an endoscopy is to have a good assessment or to detect pre-malignant or malignant lesions, which would require more time, I think doing it under propofol would be much better. For the purpose of this study, the only intention was to check for improvement in the visibility scores. We did not spend more than 5 to 10 minutes in each patient. But for doing a good assessment, we might need around 20 to 30 minutes for individual endoscopies. And I think for that, maybe doing it under propofol might be a better option.
But the propofol gives a deeper level of sedation. Do you think there can be a higher risk of aspiration? You're already given the patient 100 ml of water. So while giving the anesthesia, do you think there can be higher risk of aspiration?
So even despite inflating the stomachs completely, we did not find any significant gag. 100 ml of water, I think, is quite insignificant. And even after we intubate the patient and go into the stomach, what we usually do is first aspirate whatever excess fluid is there. So I don't think there is any significant risk of aspiration with this amount of fluid, irrespective of the type of anesthesia that you administer to the patient.
So what you do, you go first to the stomach and aspirate the fluid, whole fluid first? Or?
Yes. So after we give this drink, we see that the fluid has quite layered out into the stomach and the bubbles have quite decreased. So whatever excess fluid is there after intubating, we aspirate that. So that fluid, whichever is the water plus NAC plus simethicone which was present, we aspirated it completely, and then we can see absolutely clear mucosa underneath that.
And you used any commercial preparation, or you customize it for your patients?
So when we were doing the study, we were not aware of a customized preparation, which is now available in the market. We customized it because Pronase was not available. Dr. Vedo had given us a idea that NAC can be used. So NAC was easily available. Simethicone was being used for long for other indications. So we used a customized preparation. So every time our technicians used to prepare, and they found out a very ingenious method eventually, that they used to take a bottle of Sprite and mix around 5 or 6 100 ml waters, and then mix all together and prepare a drink, and then keep filling it in glasses and giving it to patients. So that is how we performed the study eventually.
Yeah. Next question is to Dr. Veera. So do you recommend the pre-endoscopy drink to all the patients, or there is a select type of patient where this preparation should be given? So what's your practice? You giving to every patient, or?
Yeah, it's better we give for every patient because we don't know which patient will have yearly pre-medical condition. Since it is an opportunity screening only we do in our country, not a routine systematic screening protocol or any systematic screening program exists in our country. So every endoscopy which we does should be an opportunity to detect early lesion. So we should advocate this, advise the patients to take this pre-medication drink before for every patient. It's better, such that when we go inside, we suck the fluid which is remaining and then start examining for the stomach. That is the main reason I advise to take for every patient. That will be better.
Yeah. Now the next question is regarding the effect on the esophagus and the gastric mucosa. I think there are two different type of mucosa. In the stomach, we have the columnar mucosa with the mucus glands. They secrete a lot of mucus. And while esophageal mucosa is the squamous epithelium, which doesn't secrete the mucus. And when we are doing the endoscopy, most of the time it's very easy to see the esophageal lumen. We don't find any problem during the endoscopic evaluation of esophagus. So in your study, you found that esophageal visibility score were better in the group who received simethicone and NSL-cysteine. So any reason for that?
Probably in the stomach, the mucus will not be secreted. In the esophagus, the mucus is not secreted, but there are a lot of bubbles still exist when we are screening. Since most of the time when we do an upper GI endoscopy, we try to intubate first as much as possible into the D2, and then when we are coming out only, we should do the screening, like in colonoscopy. Means we should spend a lot of time when we are withdrawing. So when we withdraw and come back from the stomach, a lot of bubbles will usually come back in the esophagus and obscures the vision. So for that, if there is it should not be, there should be bubbles, which is, so the bubbles are the most important thing in esophagus, which obscures the vision than the mucus. In stomach, it is a mucus which obscures, and also the bubbles, both take care, both obscure the vision. So in esophagus, it is more of bubbles than the mucus, which is obscures the vision. That is why probably in our study it could have been a reason to show the difference compared to placebo and combination group.
So next question is to both Dr. Shiri and the Veera. What's the mechanism of action of simethicone, and how the bubbles are formed inside the stomach?
Can I answer that?
Yeah, please, Dr. Shiri, you proceed with.
Yeah, so I briefly touched upon it, that there is an amount of gas which is present in the gastrointestinal lumen. So when this gas gets trapped in the fluid which is present in the stomach, that is where you get the air bubbles. So the action of simethicone is based on the principle of surface tension. So whenever bubbles are formed and they have a sufficient amount of surface tension, so anything which has a high surface tension, it tends to be compact and it becomes very difficult to break it. So what simethicone does is it reduces the surface tension of these bubbles, so they become very amenable to be lysed or to be dispersed. So anything wherever you reduce the surface tension, that fluid just disintegrates, that just goes away. So simethicone is based on reduction of surface tension.
So you want to say it converts a bubble to the water
yes.
droplet,
yes.
smaller water droplet.
Yes.
Yeah. So any alternate of simethicone we have for the anti-foaming? Do you see any other alternate for defoaming agent?
I'm not sure.
I'm also not sure, because even when I tried to do the study, I could not find any agent at all. At the time, it was even not even Simethicone was very famous at the time as a tablet. So that solution was also not there. So I really consulted the Delvin and I asked them to prepare it personally, because I was not finding it. When I went to Japan in 2016, there was a standard protocol which was existing. But in India, there was no Simethicone or no NSL-16. Only NSL-16, the tablet was available at that time in 2016 when I come back. So I discussed with them to make it, and then they tested it, and then for the stability of the solution, and then they gave it to me. Then I also did a pilot study before starting the RCT. And in the pilot study also, I was convinced that okay, this is doing something little bit better than that. And then only I started the study. So as far as I know, I think so. There is no dimethicone available in our country. Dimethicone is the only thing as an anti-flatulence drug available.
And again, do you think aggressive flushing can be a substitute for the pre-endoscopy drink? Aggressive flushing can do the same job?
Sir, in practical experience, I don't think it is a substitute for a pre-endoscopic preparation. Whatever aggressive flushing you do, you're not able to achieve the same quality of pre-endoscopic preparation as you are able to achieve with these preparations. It is really different. It is really excellent.
And do you think that it will translate into the more detection of early lesions?
Yes. I have been in touch with Dr. Mohapatra, as Dr. Vedu said, and he himself has vouched that there has been a transformation of his practice. He has been doing NBI very frequently, and he has been giving preparation to all his patients. And in a month, he's been finding one early gastric cancer, which is a huge number for any of our centers.
And I think especially we have certain belts in India who have high early gastric cancer, like in the northeast or patient in the Kashmir, they have high risk of early gastric cancer.
I think we are missing out on that, sir. That is possibly we are giving less time and we are not focusing on this aspect of endoscopy, which is really important.
Actually, I worked in a cancer center before moving here. In Adair Cancer Center, according to their data in India, it's actually the gastric cancer is also in the rise. It's a number 4 cancer in India. So I think so. Most of the cancers which are detected in India are mostly in stage 3 or stage 4 only. Definitely, at least in that, some few patients at least would have definitely undergone endoscopy. As Dr. Pradeep and Dr. Noria pointed, missed lesions also contribute. One in 398 endoscopies, we are missing the lesions, as he had pointed rightly. Definitely, this kind of opportunity screening should be encourageable.
Yeah, Dr. Veera, last question. Can you tell us?
I think so. Dr. Saurabh is also getting late. Yeah.
Okay. So, any
please,
final comment?
Please.
Final comment from Dr. Veera and Dr. Shri. Any final comment?
Sir, I think.
Proceed.
Yeah, I think we as endoscopists in India, I think Dr. Vikas, you being one of the leaders for endoscopy in this country, I think we should all promote utilization of pre-endoscopic preparation as a standard for our country as well. I think we can also follow what is being done in the best centers around the world, and it has to be done more frequently, and it really works. I think it is only a matter of awareness that has to be created by people like you at the top.
Yeah, Dr. Veera.
Sir, definitely pre-medication drink will improve our quality and also detection rate of early GA cancer, especially the stomach and esophageal cancer, lower esophageal cancers, so and upper esophageal cancer. So we should, I think so, recommend using this as a routine for all the patients. Definitely, we can detect early lesions. It's not that the high incidence countries will definitely have it, but in our country also, we are detecting most of the cancers only in stage 3 and stage 4. And because of that, stage 4, most of them will have difficult and morbid and mortality also increases. So we should recommend, sir. I think so. This is from my practice, from my learning, which I got it from Cancer Institute and Dr. Noria Yudo's center's experience, which when I was there.
I think the message is very clear. We should be preparing the patient well and spending more time doing the endoscopy. So with that, I think we can wind up the session. Yeah. Thank you very much.
Thank you, sir. Thank you a lot.
Thank you.
Sure, so thank you. Good evening to all. I think you had a very nice discussion and very interesting lectures to begin with, and followed by, I mean, after each lecture, we had a good amount of discussion also on the preceding lectures that have gone along. And the last couple of presentations from rice trials from India, that is very, very nice to see that quality of data that has been shared with us. So overall, I mean, prior to looking at this, I mean, we've not had much discussion about the use of anti-foaming or defoaming agents and mucolytics to improve the gastric or the esophageal upper GI mucosal visibility. I think this meeting has actually opened the eyes to quite a few of us here, including me, to the importance of using these agents in getting better visibility, particularly at the time when we are looking when the whole world is moving towards identifying early mucosal lesions and providing therapeutic endoscopic centers even in India. I think we should start looking at using these agents on a much more frequent basis. And so part of this panel discussion, I think I'll again request my panelists, Professor Yudo, Dr. Manoj Sahu, and Dr. Saurabh Mukiwar to join us, along with Dr. Vikas and Dr. Gary. I think Dr. Naresh Bhatt and Professor Bandari have already left, so I think probably they can take their place. We'll take another 10 minutes possibly to re-summarize what we have learned here, and I have a couple of questions here also. We have been hearing about this foaming agents, and Dr. Srihari just mentioned why they form gas. There's bubbles and these things. Is it only that what is there, air in the lumen, which is causing it, or is it something to do with the? I mean, why isn't it that we see that in every patient? I mean, is that something to do with the salivary, or is it something to do with the bile, which is reflexing back into the stomach? What exact? I mean, do we really know what causes these foaming agents? Is it only the gas amount? I mean, everyone should be having the same, isn't it? Any comments, Professor Yudo? What are his thoughts on?
I'm not sure, but maybe some, usually saliva or bile, everything contains some mucin. So probably it makes it more bubbly compared to plain water. So that is just my opinion, feeling. Maybe Srihari knows some content, real content as a scientific,
Hi.
Yeah, sure.
Make a comment. See, I think we always see this in colonoscopy, and putting simethicone as a defoaming agent in colonoscopy is sort of routine practice. So I wonder if it's to do with gut bacteria in ways, and that leads to the formation of all the bubbles and foam. Any thoughts? Sherry, you've sort of done a lot of thinking on this front.
So I had tried to review a lot of literature on what actually causes these bubbles. Only two things I could find out. One is the ingested air that we ingest, and the second is fermentation by the gut bacteria, which produces a gas. So it is around 20 to 30 ml of gas is present at any point of time in the GI lumen. So it is possibly that gas which gets trapped in the fluid, in the water which is present in the stomach, and that causes these air bubbles.
Okay. And the other question is, what is the ideal time? I mean, each study has its own thing, and what's the ideal volume that I think? I mean, is it one size that fits all? I can't believe that an obese gentleman will have the same amount of gastric volume as compared to an lean individual whole thing. So, if you are looking at a gastric volume, I mean, is it anything specific that you titrate to an individual, or is it just one size fits all, like 100 ml of whatever solution that you prepare, or is there data to say that it is going to be different in different people? If the entire idea is to see if to clean the entire stomach and the esophagus, I mean, won't it be different in different people? Any thoughts from sir?
Very difficult question, but as I mentioned, I presented one meta-analysis so that it said that 130 milligram simethicone is the best, and 100 mg or 200 mg is too thick. So, so maybe some adequate, concentration is available. And also they say that 20 minutes is a good time. Before more than 20 minutes is good to dilute or the thick mucus or something. So probably there is also some very good, window, best window to digest the mucus or bubble. Maybe Sriharino, do you know some data, literature data?
So most of the studies are before 30 minutes. So you have to do it before 30 minutes and anywhere starting from 5 minutes. So 5 minutes to 30 minutes is the window where you do the assessment after you give this drink. Anything beyond 30 minutes, there is a study which clearly says that there was no difference after 30 minutes. And obviously for it to act, we would require some time. So maybe 5 minutes is a good time. So anywhere between 5 and 30 minutes should be a decent time.
I have an observation in it,
context.
I have also a comment in that I would like to give it. So if we are finding that after giving 100 ml of diluted solution, if still the bubbles are there, we are always there with flushing of the simethicone also into the lumen to clear the rest of the bubbles or the mucus. So I think so 100 ml to 200 ml anywhere, as Dr. Yuvedo and Dr. Pradeep and others quoted, it will be fine, that water, because the as much as more around up to 200 ml or 100 ml we can dilute and give it, and as much as possible it cleans gastric mucosa, because surface area, even though it is large, as Dr. Srihari said, only when it is collapsed the stomach will have only less amount of air and inflation, so definitely it will mix and it will clear the thing.
I just had a comment. By any chance changing the position of the of the patient as the patient is waiting, will that impact all the entire stomach to be cleaned out better than having the patient just stay flat or be upright? Just in terms of letting the simethicone and NAC act all over the mucosa.
I heard from my senior doctor that in the past, they asked the patient to rotate 5 times and something like that. But he said that if he gave some enough amount of the water solution, it does not make such difference. So he stopped that practice. In the past, he saw that it's better to wash out the mucus in the stomach, but yeah.
So Dr. Saurabh, what off late we have been doing now with this commercial preparation which is now available, it is very easy to use. So you have a bottle which part of it contains the liquid, and then you just add water to it and then you give it. So just, I mean, for the purpose of just checking, I was now starting to flush it, this solution in patients who did not have a good preparation, and I could find that even after flushing immediately. Now the simethicone is a kind of an oily solution. It is an oil-based liquid, so it actually layers out pretty well. As soon as you flush it, you can see it layering out all throughout the stomach. So you don't have to do any elaborate maneuvers to make sure that it actually goes around in all surfaces. It smoothly coats all the surfaces quite evenly and immediately. So
yeah, that's a good point. Actually, I train in the West, and where there are too many gas and bubbles in the patient's colons for whatever reason with the sort of diet, I suppose. But we used to routinely put simethicone. And as soon as there were too many bubbles, and we were doing colon cancer screening, as you can imagine. So we obviously wanted to look at the mucosa very, very well. And using simethicone in practice was a pretty standard thing. Like I see bubbles, immediately I ask them to put simethicone. And as you correctly pointed out, it's very quick. It works really fast. Suddenly all the bubbles are gone. It really works wonders. So I think it's great, and it's interesting that we can now do it for upper GI endoscopy. And now, especially for our country, where it'll be exciting to pick up more early cancers and really make a big impact. Of course, we need a larger study to confirm that, but yes, I think it's exciting. I did have a couple of points or questions. So I wanted to ask Veera, in your study, you did compare with 4 groups, right? So you had placebo, NAC, simethicone, a combination. Prior meta-analysis did not show any benefit of NAC plus simethicone over NAC or over simethicone. Now, I suppose you did not power your study to find that difference. You only compared with placebo, and all the groups did pretty well. Was there any difference between the groups? Do you think NAC and Simethicone are absolutely better than only NAC or only Simethicone?
Sir, in my slide I shown most of the locations where the total mucosal visibility score has been calculated. It has shown that total mucosal visibility score was better in upper corpus, esophagus, lower esophagus, and also in the antrum, and all pretty well differentiated between placebo and the combination. And in one area which I showed, the lower corpus, that is the thing where when I compared with other groups, the combination performed better, and also with group A and group B, which is B is a simethicone alone, the significant value was not there. P value was not significant. Means probably in the lower corpus and the antrum somewhere, probably the simethicone is not combination is not over picking up than the NSL16, but still overall, if you compare with other groups, it was showing better one.
There's a
The
question
question was
from,
very nice. I was also thinking that one when I got the result, but it was a good one. After that, only the pooled meta-analysis came actually, but still before that itself, my study I done it, but still under peer review only. It's not been published yet under peer review.
Yeah, and even the duration
a
of
question one from the chat box as well. Sorry.
Yeah.
There's one question from the chat box from the audience. We'll take that as well. So how palatable is this new, this drink of, combination of N-acetylcysteine with simethicone? What has been the feedback from people who have been using it? Is it palatable or is it hard to drink? How has it been? Is it an oily based drink? So what's been the feedback?
So in our study, we used N-acetylcysteine, and that was a orange flavored effervescent tablet.
Custom made one.
Not custom made.
You made it.
No. Yeah. So we used that. We custom made the preparation, but these NAC tablets were already available in the market, and they were orange flavored. So none of our patients actually complained of any alteration in the taste. Even the recent commercial preparation, which is now available, we have been giving it frequently to the patients, and none of them have any complaints of
nausea,
nothing.
Okay. And there's one more from the chat box. Okay. I think we've taken that question. With all these data that is coming up, where you say that you can give about 100 ml, 200 ml, even a half an hour before the start of procedure, even under sedation, where you report there is no need, no risk of aspiration. Is it time to change our rules that you say, you can take water even a half an hour before your procedure? Why do we still stick to like 2 hours of no liquids?
I think that is the entire intention behind this seminar, this webinar. We need to really change our practices. In Japan, it is followed very differently from what we follow here. The notion of strict fasting for longer periods of time is not actually required. You can allow the patient a few liquids, and this pre-endoscopic preparation, I think we must encourage it very positively among everybody and in all the centers.
Dr. Sahu, what has been your experience here? Your anesthetists are mighty afraid when we say that he has had a liquid about 100 ml half an hour before. What has been your experience? Have you been able to convince your anesthetists to allow some people to have this prior preparation?
Thanks, Dr. Pirama. We are very fortunate that we have anesthetists from morning till evening every day, but they never allow drinking water at least 1 hour before the procedure. But we have data that there is no aspiration. But if this is true, then we need to change our practice. So we need to advocate this thing in our routine endoscopy. One question can I ask, Pirama?
Yeah, please.
So suppose some studies, they mentioned that the visibility of D2 is not very significant. So then what should be the optimum volume of the mixture to make that visibility of second part of duodenum better? And there is no mention of mid and upper part of esophagus visibility in any study. So can you prepare the entire upper GI with some optimum preparation? The optimum volume should be 100 ml or 200 ml. So how to make the visibility of the entire upper GI, esophagus, stomach, and up to second part of duodenum very clean?
Any thoughts on Veera, Sri, Professor Ido? Dr. Saurav.
Sir, the liquid emptying time means in gastric emptying time, for the solids it is around 3 to 4 hours, and for the liquids it takes minimum from 20 minutes to up to 1 hour also it will take. So every patient will have different kind of liquid emptying time to get the duodenum to be prepared. So uh, I don't know. So that the time duration differs, the amount of the when we have to ingest this drink, all these things will differ for each and every patient. Since there was a huge variation between 20 minutes to 1 hour for the liquid emptying time, so definitely it will. I don't know. There is no study which says exactly that how much solution should be given and to prepare the duodenum actually. So I don't know about that one, sir. This is my thought which I had.
That's a
Maybe
good
in
point.
practical point of view, maybe we just use a syringe flush to access, area. Not so. I think not necessary to, whole the upper GI tract should be, clean, prepare with one drink before the procedure. In just a practical point of view.
Have there been any concerns about using this preparation as far as the endoscopy reprocessing is concerned? Does it give any trouble at all?
In a practice, basically no. So one thing is if you put the Symmetricon into a water jet bottle, so it go through the very narrow nozzle or channel, so it can make some crystallization. But just a large or working channel, I think it doesn't matter at all.
Oh.
Yeah, so this point I had reviewed during the review of this literature. So when it was being used in the water jet, so there is a circulating letter which is even now available online. So Olympus had come up with this advisory that don't use simethicone in the water jet, because what it was doing is it was crystallizing inside, and there was a higher incidence of biofilm formation when it was being used in the water jets. But they advise that you can use it as a flush where it would not cause any crystallization, not cause any sedimentation. So the only recommendation is to not use it in the water jets. You can use it as a flush separately, or you can give it as a drink. In those cases, there was no impediment with the reprocessing of the endoscopes.
When we suck out those content, it doesn't cause any problem. When
No, that has
the
not
water
been.
jet component, it is a problem.
Yes.
And when you flush it with this thing, it doesn't cause any.
Yeah, that is what.
That is also because probably the reason is in the scope, if you see the biopsy valve, the channel, the water sucking channel is different and the water jet channel is different in the scope. So there are two different openings which is there. So probably in the biopsy channel wall on the water sucking channel, there is no biofilm formation, and only in the water jet channel, the biofilm formation is there, I think. So that is the reason why they are saying. That's what I found logically.
Dr. Saurav, what do you think will be, is it possible for us in India to adopt this to all patients, or do you think you'll suit and pick and choose your patients where you're going to, in practically, it will be ideal to use it in all patients, but would you pick and choose some patients in whom you probably would elect to use this as well?
See, I think the major challenge in India, by and large, is always a cost, is a barrier. And given that it's cheap, I think that barrier is not there, number one. The second thing is it's easy enough, it's palatable, so I don't think it's going to be a problem to use it in all the patients. And third thing is, filtering out and having these screening processes in place that only above 50 with history of smoking, I may decide to do this, or family history of gastric cancer. I think that gets very impractical. I think the easier thing to do is to apply to all the patients. And I feel it's easy to it's cheap, it's easy to do. And if it's applied to all the patients, you'll probably find early cancers and better mucosal visibility throughout, and lesions that you would not be expecting. So I think it's a great development, and I'm really happy that I was part of this session, because I am definitely going to institute in our center beginning Monday that we use it in all our patients. And I think it's much easier to not filter it for a certain subgroup, number one. I think the more important challenge is the more scheduling And all our practices are different. Some use sedation, others don't. The timing is not like, it's 8:30 doesn't always mean 8:30. It can be 8:45, it can be 8:20, probably always later. So that can be slightly a bit of a challenge in terms of getting the timing right between 10 and 30 minutes before the procedure. But barring that, I don't see any barriers to do this. So I would definitely institute, yeah.
Thank you. I mean, I'd like to thank all the panelists. I think we are just running short of time. I think I've been having a wonderful panel discussion. I thank all my co-panelists, Professor Guido, Dr. Manoj, and Dr. Saurav, Dr. Vikas, and all Veera and Sri Hari for being part of this. I think we'll end this session and I'll hand over to Dr. Ubal for further proceedings.